Okay, hi everybody. My name is James Buchanan. I'm a senior lecturer in health economics at Queen Mary. Also involved in the evaluation of the generation study, which I'll talk about a little bit more in a minute. Thank you very much to Annika and everyone at CPM for the invitation to speak today. It's a really interesting time for doing research in the context of health economics and newborn screening, and looking forward to all the sessions today. I'm going to talk about how we might go about building a health economic case for extending newborn screening to incorporate information from genome sequencing. I'll talk a little bit about the current health economic evidence base for screening, what evidence we ideally need to form solid conclusions about cost effectiveness, and I'll talk a bit about the work that's underway to evaluate the generation study, the work that's underway more globally in terms of health economics, and then the challenges we might face over the next few years. By happy coincidence, rather than any feat of planning, I think I might actually be saying many of the same things that Anne said in the first session, but just with more weird health economics terms rather than Anne's more direct approach. Let me skip forward. Here we go. So to address the overarching question first, why do we actually need to build a health economic case for newborn screening? I'm sure I don't need to tell everybody we now live in a world where there's a lot of things that we do in healthcare, new treatments, new procedures, new surgeries, just generally new healthcare interventions that cost a lot of money, and at the same time healthcare budgets are always going to be limited. We can't afford to meet the entire demand for healthcare that exists in the population, so we have to make difficult decisions about which treatments, which procedures, etc., are going to be made available on the NHS. And there are several factors that are taken into account when we make these decisions. A key consideration is often cost effectiveness. So the cost effectiveness of a new healthcare intervention compared to perhaps what happens in existing practice. Every spending decision in the NHS has an opportunity cost. Normally, it's only the health economist in these sessions that mentions the words opportunity cost. So again, it's really nice to hear Anne mention that. If we fund a new application of genome sequencing, that may benefit patients with a particular rare disease, for example, but it also means that other groups of patients in the NHS have to miss out. So this can take lots of different forms. It might mean that we provide fewer hip replacements. It might mean that some other genomic test is not provided, and so on and so forth. Newborn screening is of course one of many different things that we could do to spend our health budget. So of course evidence on cost effectiveness is required to support any extension of the current offering. Because the extension that we're thinking about specifically is genome sequencing, which is still relatively expensive, and it has potentially significant short and long-term health and non-health consequences, it makes it particularly important that we carefully consider the balance of costs and benefits before committing to an expanded screening program. So all that said, in the context of newborn screening and genomics, the relevant decision makers in England are, I think, a little bit unclear, and the importance of economic evidence can be questioned a little bit so far. So in England, decisions about whether or not to implement new healthcare interventions are usually made by NICE. We've already mentioned NICE. Evidence on cost effectiveness is a key factor in their decision-making process. But decisions on which conditions are considered in the newborn screening programme have typically been made by the NSC. The NSC also consider health economic evidence as part of their processes, but there are some differences in how that work is undertaken by the NSC, and we've already talked about the very sort of high standards for evidence that feeds into that process. For example, a further element to add to the mix here is that genome sequencing in England has moved from the research setting in the form of the 100,000 Genomes project to the clinical setting in the form of the Genomic Medicine Service, without really undergoing formal economic evaluation. So although we can probably, I hope, all agree that economic evidence is theoretically important in this context, the type of evidence required and the role this evidence plays in decision making in England is at best a little bit unclear. So let's have a look at the current health economic evidence for newborn screening. Here I have to thank a colleague of mine, Lexi, who recently reviewed the available evidence on cost effectiveness of newborn screening around the world. Lexi searched for the past over the past 35 years and identified 27 economic evaluations in the published literature, mostly undertaken in the UK and the USA, covering the conditions that you might expect to see, so cystic fibrosis, combined metabolic disorders, and severe combined immunodeficiency. Just under half of these studies, 40%, were cost utility analyses, with outcomes expressed using QALYs, which is the metric that's preferred by health technology assessment agencies. All of these studies, and I'll come back to this point later, all of these studies considered the cost effectiveness of screening on a disorder by disorder basis. And in over 3/4 of these studies, the authors concluded that screening was cost effective. If we look specifically at evidence for the UK, I've pulled out here 5 key economic evaluations that have informed decision making, covering the disorders that you can see in the table. In most cases, newborn screening has been found to be cost saving or cost effective in comparison to the standard NICE thresholds of £20,000 to £30,000 per QALY gained. Even for tyrosinemia, there are several scenarios in which this is potentially cost effective despite the high ISA in the base case. And I'm mentioning these studies to highlight, I guess, that in general, historically, convincing evidence on cost effectiveness has been required from carefully conducted research studies with, in many cases, quite extensive evidence synthesis for conditions to be added to the newborn screening programme. So I think this is the starting point that we should be considering when we're thinking about building a health economic case for implementing newborn genome sequencing. So how is this case being built for newborn genome sequencing in England? As has already been described by several of the previous presenters, and I'm sure you're familiar with already anyway, the Generation Study exists, it's underway, and the aim is to deliver sequencing for 100,000 newborns in England to explore the benefits, the challenges, the practicalities of this extension to newborn screening. And as part of this work, there's a process and impact evaluation that's underway, funded by Genomics England, but it's an independent mixed methods evaluation of the Generation Study. As you can see on the slide, there are several components to this work. Study 6 is the study that's focused on health economics, and this is work that we're leading at Queen Mary. The aim of Study 6 is to evaluate the impact of newborn screening, newborn sequencing on healthcare resource use and costs, on quality of life outcomes and non-health related outcomes, and then to feed these results back to health economists at Genomics England as part of their economic modelling work. So more specifically, we're looking to estimate the cost of sequencing, the cost of implementation and scaling up, the impact of newborn sequencing on healthcare resource use and costs, and also out-of-pocket costs for families. We want to estimate the impact of newborn sequencing on quality of life outcomes in children and quality of life and non-health outcomes in parents. And then for all of these parameters, we're estimating values for both children undergoing sequencing and their families, and also, where possible, and we think this is quite important, appropriate comparator populations to try to account for the fact that data isn't being prospectively collected for newborns who are not undergoing genome sequencing. So while we undertake this evaluation work, there are health economists within GEL who are also constructing a decision model that is trying to incorporate all the available information on prevalence, on natural history, costs and outcomes for all of these 220 odd conditions that are part of the Generation Study. As you might imagine, this is a mammoth undertaking, so the approach that's being taken is possibly slightly different to how this has been tackled in the past. Whereas the NSC have typically evaluated the cost effectiveness of adding individual conditions on a sort of disorder by condition basis to the existing screening programme. What GEL are doing are modelling conditions in broad disease groups and evaluating the cost effectiveness of the proposed expansion as a whole, not at the condition level. And of course, there are advantages and disadvantages to this approach to building an economic case, and we can perhaps return to these in the panel discussion. The evaluation work that we're doing isn't happening in a vacuum. So you may be familiar with ICONS, the International Consortium on Newborn Sequencing. Within ICONS, there's an economics subcommittee that I co-lead with Hadley and Miranda. And what we've been doing, or at least starting to do within that subcommittee, is to try to bring health economists together around the world who are working on newborn genome sequencing studies to try to encourage data sharing and some alignment on methods. One example of an area where this may bear some fruit going forwards is the measurement of health outcomes in newborns. There are very few instruments available that we can use to measure these outcomes at the moment, but we're trying to develop a consensus to use the newly developed Europol EQ TIPS instrument across multiple studies to build a stronger global evidence base for this parameter. And we're also aiming to develop a framework for the economic evaluation of newborn genome sequencing. And hopefully this will be useful to guide the evaluation of the next wave of newborn genome sequencing studies around the world. Hopefully these are all positive steps in terms of building an economic case for newborn sequencing, but of course there are also many challenges on the horizon. And these are challenges that we've been discussing within the health economics world. We had a go at summarising these challenges in a paper we presented to health economists last year, and we've broadly grouped these into 6 categories of challenges. And the first relates to how we go about doing the cost effectiveness modelling in this space. So I've already mentioned the condition by condition approach to modelling cost effectiveness. That might be tricky in a newborn genome sequencing world. So how do we deal with this as health economists? We also need to build models that accommodate potential expansions in gene lists in future years. And at the same time, we've got to deal with some quite uncertain evidence and these evidential uncertainties that will vary over time. There's uncertain data on penetrance, on expressivity. That's a challenge as well. And fundamental questions are quite difficult to answer when we're building models, such as identifying the correct comparator in these analyses. That is going to vary on a country by country basis. The second category of challenges relates to how we evaluate outcomes, not just for newborns, but also for their parents. For newborns, I've already mentioned, we have few validated outcome measures, outcome instruments that we can use to measure impacts on quality of life, although hopefully the EQ TIPS instrument might become increasingly useful over time. For parents, if we're thinking about psychosocial benefits, personal utility benefits, and harms, of course, we have more options in terms of instruments that are available, but the flip side of that is there's a significant potential for a lack of harmonisation around the world, which restricts data sharing over time. And then there's, of course, the challenge of combining outcomes information, outcomes that accrue to both newborns and to parents in one evaluation. The third category of challenges relates to the sort of the analytical scope of the studies that we will conduct. So in England, Ellen has already outlined, the main focus so far is that first pillar, if you like, looking at the cost, benefits, etc., of generating this information, using it in the first 5 years of life. But there are also key objectives for the generation study to think about the potential benefits of future research and the benefits of having genomic information in a database that can be used across the life course, and to what extent should we attach value to these potential benefits in our analyses. The fourth category is behavioural considerations, and this has been mentioned by several of the presenters so far. We have limited evidence on the acceptability and the likely uptake of newborn sequencing and how families might make decisions when confronted with a diagnosis. And I would add to this also, we also need some good information on the potential impact on the existing newborn screening programme to ensure we don't do harm in that direction. All of these factors could impact on potential cost effectiveness as well. The fifth category captures a more global challenge, which is that over the next 2, 3, 4, 5 years, different countries around the world are all going to make different decisions on the implementation of newborn sequencing, because they'll come to very different conclusions about cost effectiveness based on local conditions, local considerations. There's already some, several papers in the literature documenting the fact that gene lists differ quite significantly across all the different studies. This may or may not be a problem. This might be an easy thing to explain to the public, or it might be a hard thing to explain to the public. But that's something that we need to consider as health economists. And then the final category of challenges I've already touched on a little bit, but they relate to decision making. It can be quite challenging to identify the right decision maker or the appropriate decision maker to consider health economic evidence. And I've already mentioned in the UK we have NICE, we have the NSC, we have decision making happening at a sort of a higher government level on implementation that may or may not use health economic evidence. And how do we as health economists navigate this quite complex landscape? So to quickly wrap up, in terms of where we stand in terms of building a health economic case, I think the need for a strong economic case is obvious. I hope it's obvious, and the standard has been set by past work in this space in terms of how robust this evidence needs to be to support implementation. It's positive, I think, that there are a lot of health economists involved alongside all the newborn sequencing studies around the world. From quite an early stage, I think this gives us the best chance of collecting the data that we need to build this economic case. But there are quite a lot of challenges ahead on the health economic side. Building a convincing economic case is going to require data sharing. It's going to require methods alignment around the world to try to offset some of the limitations of current study designs, such as the limited prospective collection of data for comparative populations. And we're working on that.